this is the CPR report. Some of you burned it, some of you trashed it, some of you said fuck it. I know, I get it. But if you're lucky, your state emails it and you don't have to worry about it's gone forever. A lot of times they used to mail it, and if you trashed it, it's gone forever. This paper right here dictates how you do this down here. So if you look at this person, I'm looking at right here, she has all nears, 2 aboves, and 1, 2 belows. Now, our issue with our students is that they would say, I almost passed, I got all nears. No, you didn't. You ain't come nowhere near close to passing. So just because you get all nears means absolutely nothing. I have seen the student that got all aboves and 1 below. You got all nears, that ain't nothing. So don't get wrapped up in nears, because I find that leads you to believe you don't have to do a whole lot. Yeah, you do have to do a whole lot. You never mastered anything. This young lady mastered basic care and comfort. I remember her saying, because she saw a video that said you fail in that somewhere, and so she thought she'd pay attention to that. But the rest of this is nears, and her belows are in this section. So if I was counseling her, I would say you are very different, because most of my students get their belows up here and they get their aboves over here. Typically the only aboves I even see on your test are in here, okay? Everything else is near or below, and that's because everybody paid attention to case studies, and so they worked their ass off trying to do this. They didn't understand that just basic ass nursing was part of the deal. Okay, so all you have to remember is this test is all aboves. Now, how do you stay in the aboves when you're answering questions? How is it that you do that? Well, let's say that the test question is, what is the #1 cause of cirrhosis? What would you say? Yep, you would be right. But the problem is, when you said that, that was a little bit of a dummy down question. So that question was just like, okay, you got it right, so what, right? Kind of thing. Now, when they get more complex, let's get more complex with that same topic. Let's say, what causes ascites in the cirrhosis patient? That question is not going to get a forceful answer from the whole class the way the alcohol question did. And so that would be considered a higher level question. If you can answer that question, then you get above. In other words, your job is to answer as many higher level questions as humanly possible. Stay away from dummy down. How do you get dummy down? You missed normal. They gave you a normal question and you didn't get it right, and they had to dummy it down. You get too many of these and you are kicked out that test, 85 and out, or whatever it is, okay? If you stay way up here, you're gonna be out of there in 85. If you go back and forth and back and forth and back and forth, but you get some up here, you're probably 150, but you failed. So your job is to stay above the grain, right? And so what does that mean? That means that you must master it. That's what it means. It means that anything they ask you on any of these, you can handle the business because you mastered it. Okay, that's what this whole program is all about. So truth be told, many students don't understand that some of the software that exists out there that says, oh, you got a great chance of passing. Typically, they're using the score of 65 and up. But my deal that I tell you guys, and I want you to hear me from my heart, 100% of students that have an average of 60s fail. I don't know why the software is misleading for you. I don't know why Archer and even UWorld and some of the others say, you got a decent chance of pay. No, you really don't. Because if you just use common sense and you think back to just what makes sense. I always say, make it make sense, Jesus. You know yourself that 60% is failing. 85% on the other hand is passing. So this is why. And then when we look at our LPNs, we give them a little bit lower threshold of 75 and 70 simply because they bought an RN software. The software is RN. It's made a little bit more difficult. So a 75 on this test for an LPN is perfect for them to pass. Does that help a little bit why I prefer the RN software? Okay, so that is just the deal, beloved. And this is where we have this board up all the time, every day, all day. So I'm going to erase this part, but you already have it.
So you have to get above on all of them?
Absolutely.
Because I keep hearing people say, like, you got to get the near pass.
No,
so
near means you suck at higher level.
Because I wondered that.
A lot of people ask me that.
They don't send their report, which sucks. So
what happened?
When the person passed, they don't send the report.
Oh, no.
But that's why we all just been guessing. I'm in so many groups, and they were saying like, "Oh, you have to get near and everything, and a few above."
Because I've had near and everything, literally every single thing, even no aboves, no belows, just nears all the way down the page, and they're in my class.
You got to get above and everything.
Makes sense.
Yeah.
You're fucking saving lives.
Yeah.
Near does not save a life.
Right.
That's how you gotta look at it. And it's really weird because I hear it all day long. I almost passed, I got all nears. No, actually you didn't. It just means you knew basics. And basic is good though, but you have to stay above in a significant amount of questions to pass. You have to come up a little bit because you figure you're taking a test in a nice little quiet environment. You're not taking a test at a hospital with 6 patients and 1 is screaming. You still got to think logically and save that life. With all the chaos we deal with, both Sarahs and people hollering at us and doctors calling us and managers on bullshit and co-worker didn't show up and got double the patients till an hour from now when we get help in here and COVID got everybody fucked up. That's real world. So near is never good enough for that type of world we live in. Okay, so yeah, it's bad, but again, I don't think that this test, in fact, I say it like this. I have had people that failed that old test repeatedly. One stab at the new one under me and they got it right. Because a new test is, I'm sorry, it's easier. It is easier. The issue of why everybody's failing it is because your schools suck. And they didn't used to suck, guys. They didn't. But the stuff I see going on in Florida is highway robbery. It's fraudulent. It's sad because after you fail that many times, now you have to pay them $2,000. And then you have to go, you failed 3 times, you got to pay them $2,000. And then you got to start all over again. And it's absolutely horrific. And God forbid you fail another 3 times, 2 more thousand. It's just a racket. Okay, so depending on your state, it could be really rough. Okay. All right, beloved. Let's do this. Let's go to EKG land. We're almost done. It's not that bad, but it's a little bit more in depth as to what we're going to do about it and what caused it. Do you remember us talking about the bradycardia? It's not enough to know it's a oh, let me say this because sometimes y'all don't read the board. You will be asked to leave if I see your phone. You paid me to teach you, and now you're sitting and you're on the phone. Figure out which one's your priority and gladly leave until you can come back. I am trying to get you so together that when you leave here, you're good. And part of that does not include a phone. So please, please, please try your best to pay attention. Okay. All right. Now, so here we go. Let's look at the bradycardia and decide why that even happened and when you care. It's a real quick scenario. The bradycardia is a heart rate less than what? 60. Very good. Heart rate less than 60. Is it always bad? No, it's not always bad. What makes it bad? Yes. Positive signs and symptoms make it bad. The asymptomatic patient, it depends. So what do I mean? Well, I don't want you to be an absolutist. I had a doctor who was an absolutist. His absolutism was, her heart rate's in the 30s, but she's not symptomatic. Well, when do you exactly draw the fucking asymptomatic line? Somewhere around 8 beats a minute. Is that cool with you too, long as she's not symptomatic? Where do you draw the line? Do you see where we're going with this? Because I said to the gentleman as he's walking out the exam room on the phone, I said, where are you going? Your patient here is having a heart rate in the 30s. Well, she's asymptomatic. I said, but when do you draw the line? I think 30s is pretty low, okay? With a history that is very concerning. So maybe they don't have signs and symptoms, but they're really low. 30s is never to be ignored. I'm sorry. I don't care what your doctor said. They just as dumb as a box of rocks. It happens to every field. So this lady, but for the record, that he walked out on and had to come back because I wasn't having it, she not only had a potassium of 2.7, but she was in complete heart block, 30s, and she also coded the next day. So you want to run that by me again, how she was asymptomatic because she came into an outpatient setting and talked to you. I don't give a damn. I have enough brain cell activity and a couple of synapses to know 30s don't sound right on anybody's EKG. But she wasn't complaining of anything. My problem is she had fallen twice that week, because this is why I'm trying to get you to watch Straw so you catch it all, because I catch it all. When I talk to patients, I catch it all. She had said she fell twice that week. I wonder if she fell because she was dizzy. That's a symptom. She had a history of AFib. She hadn't been on her anticoagulant for a week. That could play a role. She had to prep for the procedure. I don't know if you understand what preps do to your human body. They make poop come out of you till you ain't got no more, and then you still got to make more to come out. What happens when you are pooping your lungs out? Potassium disappears. All preps cause a low K. It's just that most people can handle a low K. But when you have a history of a heart problem, AFib, and you're on an anticoagulant, you're overweight, you failed twice, and diabetic, and I could add more, but I won't because you see where I'm going with it, I think 30s is not okay. That's how you got to do. You cannot look at one symptom. You've got to put the whole picture together. And I got all that out of her in 5 minutes. She had no cardiac records here. She came from Pennsylvania. The place I work at, we get out-of-towners all day long, okay? We get West Virginia, we get Pennsylvania, we get California, we get Nevada, we get London, we get everybody flying to the clinic, okay? So I'm not comfortable. And if I have to give the fentanyl and the Versed for the procedure called conscious sedation or twilight sleep, if that's me, shit, y'all better get the fuck out of here. I'm not sedating nothing that's already fucking sedated as far as I'm concerned. Well, I'm gonna give her sedation and watch the 30 drop to 3? Fuck no. So y'all better get it together. So I called a rapid response. They hemming and hawing. Well, she ain't symptomatic. I'm gonna try this one more damn again. The symptom is the 30s. That is enough symptom for me. They hemmed and hawed too, wasted 2 hours of her time on the unit. Finally took her to the ER for evaluation, found out her potassium was 2.7, and then found out that she had a complete heart block. Only then did they put respect on my name. Now every time I say, hey, Dr. Shay, how you doing, girl? You better not start no trouble up here today. Yeah, okay. Okay, so we need you to understand when you look at an EKG, Yes, a bradycardia is like, who gives a shit? But let's draw the line somewhere. And my proverbial line is at the 30s myself. That's just me. I mean, that's just how I roll. I'm rolling safe. Because what's the worst that could happen? She cool. Okay. And you mad because she cool? Okay. Get it together. Okay. Now, the problem is, if this patient is asymptomatic, let's say they're 40s, they have no symptom at all. Then let's figure out why. Who's the person that has no symptoms? That's what you better remember. Because every time I get a 40s or a 50s, I say, baby, do you work out? Baby, do you play basketball? Baby, do you run? Baby, do you jog? What you do? Because your heart rate saying you in great shape. And they usually always give me a reason. I need a reason. I'm just funny acting like that. I need a reason. Okay? You on metoprolol, sweetie? Right? Because it could be meds, right? What are you in your beta blockers, right, guys? Beta blockers, and what other blocker causes Brady? Calcium channel blocker. Had to argue with a resident about that. He didn't know that. Why'd you hold her captopril? Not captopril, but the other one, her cardizem. Why did you hold her cardizem? Cause her heart rate was 48. That don't mean nothing. It's not a beta blocker. It's a calcium channel. You better look your drug up and come back and holler at me when you're done. Oh my God, you're right. Of course the fuck I'm right. I've been doing this 40 years. What the hell you talking about? Brand new resident out of school. Go on somewhere. Okay, so athletes are going to have low heart rates and you don't even care. You're like, yay, perfect little person here. Good job. Keep it up. Athletes, beta blockers, calcium channel blockers. Very common. Very common. Very common. You're going to see this all day at work. Matter of fact, let me tell you right now. A lot of people say, oh, check their blood pressure before you get my beta blocker or calcium channel blocker. Shit. Check that heart rate. That's what you better check. That's what you better check. Really take that home with you and use it. Look at your patients. If you're an aide on the floor and you're blessed enough to be able to have vital sign access to a lot of these patients, try to tie the vital sign with the meds, because your nurses are cool. They'll let you know. I know I do. I try to teach as I go. And make sure you can see how when you're in the room and the nurse says, well, sir, I'm not going to give you this metoprolol because your heart rate's kind of low and I don't want to make it lower. Be like, oh my God, she said that happens all the time. When I'm on the floor, when I work the floor, this happens at least once a day. That's why I want you sharp on it. The heart rate is less than 60, you cannot give these drugs. Okay? Dig is not very common, but you knew that was true with digoxin, right, guys? So digoxin may be another reason for this, but the ones you're going to give all day is these. Okay? All right? Now, then if you look at this, bradycardia, as long as it's not a pause after the P wave, you're good. What do we want to treat it with, everybody? Atropine. What if that doesn't work? Transcutaneous pacing. Now listen to me, everyone. I think everybody in here already knew if your heart rate too slow, you need a pacemaker. Are you still with me? Yes. Okay, this is just a little step further. Watch this. Remember how I said if the meds don't work and the heart rate's fast, you need cardioversion. Okay, that's not true for slow. Slow is this fancy word, and yes, you need to write it. Transcutaneous, long word, pacing. And you go, no, you got the right answer when you see the pacing. Just think pacemaker. Okay, cool. I want you to turn real quick to EKG number 7 real quick. EKG number 7. Okay, let's examine it. Do you see P waves? Yes. Are they hugged up? Yes. Are there QRSs? Yes. Are there T waves? Yes. Now count the rate, please. Okay, 160. Now, we have a rule. Make sure you write it on this strip. And I think this time around when I printed some of these, I gave you extra paper after every set of EKGs. So when you get home, you can organize your notes on those blank pages. Now, so here we go. Any heart rate greater than what? 100, but less than who? 150. Write that down. And in case you're like me and was real bad with these symbols, look at this symbol right here. It looks like a little crooked L, doesn't it? L for less than. Okay? So if the heart rate's greater than 100 but less than 150, what would that be called? Tachycardia. Simple, plain, uncomplicated tachycardia. Are you with me?
Yes.
The problem is, once you hit over 150, what do we call that heart rate? SVTs. Supraventricular tachycardia. So the 150 is the cutoff mark, ain't that right? That's what you got to remember. 150 is the cutoff. If it's greater than 150, you have SVTs. If it's less than 150, it's tachycardia. Now, you ain't gonna believe the hardest strip on your test. It ain't AFib, it ain't A-flutter, it ain't VFib, it ain't tachycardia. I mean, it ain't SVTs. It's not heart block. Nope. The hardest strip on your test is plain old-fashioned tachycardia, because they are going to see if you know pathophysiology with tachycardia. And they're going to give you this, select all. They're going to give you a strip to see if you know how to read strips. And then they're going to say in the bottom part, the nurse understands that the cause of this EKG reading or ECG recording could be any of these, and maybe you'll have all the causes. Or worse, the nurse knows that with this ECG writing, the most likely orders or physician orders she may receive include the following, and then you have to check which ones those are. That is higher level. The one where it says just outright causes is normal. What the strip is lower level. You see how I did that? What the strip is, any tech can do that. That's a lower level question. What caused it? That's a normal question. What fixes it? That's a higher level question. Now, if you get that higher level question, which I already told you that's your goal, to know the higher level questions, let's look at a few things that we need to do. Now you can have 12 in a select all, but typical is 6 to 8. So let's stay with that, okay? Okay, here we go.